Thank you all very much for joining us at this information session about the Priority Primary Care Centres presented by the Victorian PHNs. I'm just going to start sharing my screen. Can everybody see that? Some nods, excellent, thank you. So my name's Bianca Bell, I'm the Director of Primary Healthcare Improvement at the North Western Melbourne Primary Health Network, and I do just want to acknowledge all of the work of the PHNs in pulling this session together. Just a little bit of housekeeping, this session will be recorded for those colleagues who weren't able to make it tonight. We do have the room set up where everyone is muted, that's the sort of the setup that we have with Zoom. The chat is open though for any questions, and if you do have a question in the chat that we just think would be useful to sort of unmute you for, we can certainly do that. Oh. Sorry, was someone just asking a question then? Maybe it was just some feedback. So I would like to begin by acknowledging the traditional owners of the land on which we're all meeting today, and acknowledge that we're all dialing in from different Aboriginal lands. For me, it's the Wurundjeri people of the Kulin Nation. I would also like to pay my respects to elders past, present and emerging, and any Aboriginal and Torres Strait Islander people with us today. So just a run through of the agenda tonight. So we're joined by Marita Seeley, who's the Executive General Manager, Primary and Aged Care Service Innovation from CEMFN, who will introduce the PHNs and talk a little bit about how PHNs are working collaboratively. We've also got Catherine Whitfield joining us from the Department of Health, who's the Director of Primary and Community-Based Health COVID-19 Response, who'll introduce the Priority Primary Care Centre and the model. And good luck getting that out tonight, Catherine. It's a lot of P's and C's, a bit of a mouthful. And then I'll also discuss the Victorian PHN sort of collaboration, including sort of commissioning process, funding and timelines. We then also have time for some questions on the model, but if anything comes up beforehand, as we said, pop that in the chat. Just a note that due to probity and the EOIs being open in some of the PHNs already, any questions relating to applications will be taken on notice. We won't be answering those tonight that go outside of the model. We'll then collate those responses, circulate it to those attendees tonight, and also through PHN channels for those that weren't able to come. So anything specific to the application process will go direct to the PHNs, but I'll talk about that in just a moment. I will now hand over to Marita to give you a bit of a rundown on PHNs.
Thanks very much, Bianca, and welcome to everybody, and thank you for your interest in this program. For those that may not have had exposure to PHNs in the past, primary health networks were established in 2015, aiming to work with primary care to improve the efficiency and effectiveness of health services for people, particularly those at risk of poor health outcomes, and to work in coordination of health services and increase access and quality support for people. There are 31 primary health networks across Australia, and there are 6 across the state of Victoria. To achieve these goals, we assess the health needs of our relative regions. We commission health services to meet prioritised health needs. We work closely with providers to build health workforce capacity and ensure they deliver high quality care. And hopefully some of you on today's call will have actually experienced that. And we work to connect health services for people to encourage better use of health resources, and we aim to avoid duplication. Over the, I suppose, from where we started to work on COVID, the 6 PHNs across Victoria have had quite a high level of success working collaboratively. We are 6 different organisations, and sometimes that can be a little bit frustrating. So, for example, in this, you'll find out we've got some different timelines, but where possible, we try to be consistent. And this program, we are working collaboratively together where possible, again, to be consistent in our approach to the market. So thanks for that introduction, and back to you, Bianca.
Thanks very much, Marita. I will hand over to Catherine to step us through the Priority Primary Care Centre model, and just let me know when you want me to move the slides, Catherine.
Thanks, Bianca. And I'd just like to echo Marita's thanks to you all for giving up your time to attend this evening. And and for your interest in this this particular initiative of priority primary care centres. And I will say the name in full because the PPCC thing gets a little bit tongue twisty, as Bianca pointed out. So earlier this year, the Victorian Government committed to pilot a new model, which is a GP-led approach to dealing with urgent, but not, critically urgent medical treatment through GP-led priority primary care centres. And that initial announcement was for 5 to pilot the approach. Since then, the government has deemed that this is actually really an area of great interest to take some pressure off our health services, and has committed to a further 20, so 25 in total. And the key role of these priority primary care centres is to be located close to or in the catchment of busy emergency departments at our public health services, and to assist them by taking some of what hospitals call category 4 and category 5 conditions. So the first 5 priority primary care centres that I mentioned have been commissioned, and 3 of these PPCCs, I've slipped, are already open, and there will be a further 2 opening over the next fortnight. So this funding has been provided to expand the program, and the intent is that all of these will be open by the end of 2022, which is ambitious, I know, but the government is really keen to see this on the ground and actually having that direct impact on acute health services, as well as providing a much needed service to the community. So, as I said, it's for urgent conditions and care that are episodic. So it is not there to replace normal GP services, nor to displace the relationship between patients and their usual GP. But there will be occasions where somebody injures themselves on a weekend, can't get in to see their local GP, their usual GP, and their only alternative really under the current arrangements is probably to go to emergency departments. So this is the intent of this program is to replace that. And just by way of how it's funded, we, through the government and through the PHNs, are providing some establishment grants and also monthly operational grants to offset some of the sort of standing costs associated with running this sort of service over extended hours and 7 days a week. And then on top of that, the intent is that patient consults and any procedures that might need to be undertaken are billed directly to the MVS. Next slide, thanks, Bianca. As stated, this is intended to be an alternative to emergency departments presentations at that category 4 and 5. There are, from our data, we can see that at least 18% of presentations to our Victorian emergency departments fit into that category of primary care type presentations. So that does clog up our EDs. And obviously, if people are category 4 or 5, they will be right down the waiting order in our emergency departments, which means that those individuals aren't getting the best care either anyway, because they are having to wait. There's been a lot of interest and the accumulation of some evidence, both locally and internationally, that suggests a priority primary care centre model does support a reduction in emergency care or emergency department presentations, hospital admissions, and in some cases, shorter lengths of stay. The most off-cited example of where these centres are functional and have been functioning for some time is in New Zealand, where the urgent care clinics undertake in excess of 2.5 million consultations a year. They've actually developed their own college of urgent care. So it's really a developed model in that setting. Here, obviously, we're just starting off, and there is obviously interest too at the Commonwealth level with the announcement of urgent care centres. So the 25 priority primary care centres will operate alongside the 30 GP respiratory clinics, which the government funded to be stood up over the last year or so as a response to COVID-19 pandemic. So that will create quite a few options outside of emergency departments. Next slide, thanks. So in terms of the model and the sorts of features that it will have, it's intended that the infrastructure and facilities would be suitable for this sort of treatment, for the sort of treatment options that we would be looking at in terms of treatment rooms with good privacy, appropriate waiting areas, suitable ambulance access in case there is a need to refer patients back to an ED or to an ED, as well as having the ability to support telehealth appointments. They are intended and they're funded to be open extended hours, up to 16 hours a day, 7 days a week. And the period that we have secured funding for at this stage is 12 months from commencement. And they will take pre-booked appointments, either phone or online, referrals, whether that be from ED or from Ambulance Victoria or from the virtual ED that's run out of Northern Health, as well as accommodating walk-up appointments. There's a core staff expectation around having a general practitioner, nursing and reception staff, and that all staff need to be APRA registered, and that there is accreditation against GP standards for general practice and appropriate insurances. So the patient cohort, I will address a little bit in another slide, but the services are to people with or without a Medicare card. The intent is that there are no out-of-pocket costs to the patients, which is where the government funding comes in, that the capacity and the capability to treat diverse patient cohorts, including those that would be considered at risk or vulnerable, is included in the model. So whether that's homeless or people from CALD backgrounds or Indigenous Victorians or First Nations people. And it is for urgent but not emergency treatment. So that includes a range of fairly minor injuries, infections, etc. But as I said, I've got another slide on that. It's intended that there will be established small working groups locally, engaging both the emergency department that the Priority Primary Care Centre is partnered with, and also facilitated by the PHNs, and often bringing in Ambulance Victoria at that local level, so that there can be good dialogue about referral pathways and expectations of the different groups, having fast-tracked opportunities for patients to be referred from ED, but also similarly for patients from a priority primary care centre to be escalated up to the emergency department without having to go back to the back of the queue. There will also need to be discharge protocols with health services, and making sure that there is information that goes back to the individual patient's usual GP, or to any other services if they do need to be referred on to, say, for example, fracture clinic, so that sufficient information is provided to facilitate that coordination of care. In terms of supports for this sort of GP-led model, there is a need for good access to imaging, diagnostics and pathology, including after hours, preferably on site, but certainly close by. And it would be beneficial if there is access to a pharmacy, so that people can immediately fill scripts if required. Next slide, thanks. So the 25 busy ED departments that have been identified are listed here in the table. You'll note the first 5 are coloured because they are actually the first 5 that were funded. And as I said, they've already been commissioned and they're about either open or about to open. So we have a process underway with EOIs that will be undertaken for the rest of the 25, so the remaining 20. And you can see on that list the hospitals that have been identified. So we did look hard at our emergency department data to identify those that had high numbers of Cat 4 and Cat 5 presentations, as well as consideration of the population and community catchments, and any other existing services, as well as future services, for example, the government's initiative around community hospitals, as well as the Commonwealth urgent care centres, which I mentioned earlier. And there is also the rural regional urgent care centres, which are nurse-led, but I don't think any of our locations would interrupt that sort of service. Again, coming back to, I guess, one of the things on one of the earlier slides about not trying not to duplicate, but to have complementary service offerings. Last slide, I think, is next. Oh no, sorry, second last slide. In terms of the model and how it develops, because it is new in Victoria, we have established a governance structure where we have a priority primary care centre project advisory group where we have representatives from the RACGP, from the AMA, some other representatives from PHNs, and just a couple of other clinical advisors, as well as the chair of our Priority Primary Care Centre Clinical Reference Group. So we do have established a group to provide advice on clinical aspects of the model that's chaired by Professor Ed Oakley, who is a paediatric ED physician. And we have representatives there with ED backgrounds, ED medicine backgrounds, as well as general practice, the relevant nursing group, AV Victoria, PHNs, and RACGP. As I mentioned, we would expect that we would have local working groups. In between, we do have some sort of governance groups around the coordination of the work of the PHNs that we engage with in the department, but obviously the PHNs and providers will also engage with, and the intent is that there would be a community of practice for sharing learnings and best practice approaches. Last slide is the first cut of the sorts of conditions that the clinical reference group has considered, and has considered probably, appropriate to the sorts of care that a priority primary care centre can offer. And it's listed in 3 columns. The first grouped by theme or sort of broad category of infection, injury, respiratory, gut, ear, nose and throat, etc. They've got a public messaging column, which is sort of trying to get to plain language, plain language statements about the sorts of conditions or experiences that people may have where they can seek to receive care through a priority primary care centre. And then on the far right-hand side of the slide, we've got the sector messaging. So there's sort of translation into the sorts of usual language that you would expect to see in terms of, non-septic cellulitis, which the average person may not necessarily understand what that actually means. So this is their first cut. This is a living document. And I guess for those who do end up being providers, this is something that will be moving in response to need based on feedback and what might emerge on the ground. So I think that's...
I think there's one more slide, Catherine.
One more slide, sorry.
Yeah.
I did check through them. Oh, these are the exclusions. So again, it's just trying to be really clear. And the clinical work reference group is very keen to make sure that we can create as much guidance as possible. So at this stage, they have looked at inclusions or in scope, out of scope, but they will also be considering a range of other aspects of the clinical care. And again, as I said, we'll be very happy to take suggestions on areas that could be further developed or guidance developed on from those involved in the delivery of services. So I think that's it. from me. Thank you very much, Bianca, for driving.
No problem. I'll just move on to sort of the Victorian approach that Marita sort of touched on about us working together. And just, Catherine, sorry, it was an oversight when I was having a look at your slides. The Royal Children's EOI is not yet out. That will be out as of next week. There's just, because that's going to look a little bit different, but more information will be coming out through the usual channels for that. So each PHN is commissioning priority primary care centres in their respective regions. As Catherine said, the 5 proof of concept sites are currently being commissioned and progressively opening from late September, and we've got 3 of those open, as Catherine said. So for the additional 20 priority primary care centres, each PHN is running an expression of interest process, and that's promoted through the existing PHN channels. There was an initial Victorian Department of Health advanced interest EOI. So clinics that did respond to that initially and are interested in these sort of tranche 2 sites, we're calling them, will need to submit an EOI via their respective PHN processes for these new sites. So if you put in tranche 1 and weren't successful and are now interested and meet the criteria, you could consider putting in a response this time. And PHNs are working together to support the PPCC implementation, really underpinned by a data-driven quality improvement collaborative approach. And that's very much what Catherine was talking about with the statewide community of practice, bringing the PPCCs together for shared learnings, talk about challenges, talk about pathways, and really work through that as a group and build that learning across the state, which I think is really good. And then some work that the PHNs have been doing around some consistent data collection across all the sites and making that as easy as possible, etc. So this is a high-level overview of the commissioning process and timelines. And as Marita touched on, we all do have slightly different timelines. So as of today, apart from the Royal Children's EOI, as I said, all of the expressions of interest have been released by the PHNs. And you can see with the closing dates do vary between the 26th of October and the 16th of November. So they do vary, just to make sure that you're aware of the closing dates for your local PHN if you are submitting an application. Because, as I said, the staggered EOI, the closing dates are different depending on each PHN, but all PHNs will go through a process of evaluation panels and following up with any clarification meetings that are required with applicants. As Catherine said, it's an ambitious timeline, but we are aiming, to have notifications to applicants sort of the 5th of December with services to commence the 31st of December. So this is really where we're aiming to get to. Appreciate that there are certain timelines and dependencies and things, but that's certainly just at a high level where we're wanting to get to, and obviously the 25th today being the information session. So the expression of interest process, as I said at the outset, as the tender process is now active, we cannot share information about applicants due to strict probity conditions, and all questions that related to this EOI must be submitted through the relevant PHN channel, and we'll be sharing those frequently asked questions statewide. Timelines are fixed. As we've said, the timelines are pretty ambitious, and so not in a position for any extensions to be granted. So please do make sure you're aware of the closing date for your PHN region. And the funding, which that's just reiterating what Catherine touched on about the initial establishment grant and then a monthly operating grant available through the process. So closing dates for expressions of interest, this slide just lists when the EOI closes for each of the different PHNs, being aware that PHNs may have more than one site that they actually have an expression of interest for in their region, the closing dates and where to go on the website for information. And we can make these available online so that you have all of those. So that's it from a presentation perspective. I'm just going to stop sharing my screen so I can see people. But really an opportunity, whether Catherine or Marita, whether you wanted to add anything else, or an opportunity for any questions from anyone on the line.
Yes, if I may, Bianca.
Go, Marita.
For those people that haven't participated in a tender or an EOI process with their local PHN, our systems are set up so that there cannot be any late applicants. So I very actively encourage you to get yourself registered through your relevant PHN, receive the documentation, and do not leave things to the last minute. So don't at 5 to 4, if the closing time is 4 o'clock, press the button. Most, I can speak from my PHNs, and I'm pretty sure this is consistent across the regions. Most of the platforms have help accesses, so you can get assistance if you're having problems, but that assistance takes time. So let's do that the day before in case you need an issue. But I really don't want people to miss out because they started to try and put their application in 5 minutes before the closing date. I think that's really important because we want to hear from you.
Really good reminder, Marita. Does anyone have any questions? Yes, there's a question in the chat around having access to the presentation. Yes, so this has been recorded and we can certainly make the presentation available as well. We'll be able to circulate that out to the PHNs tomorrow. Question around the monthly funding be variable or fixed funding?
I would describe it as fixed funding. Variable sort of varies on, so I guess, hours or volumes of throughput, etc. So that's your MBS component. I guess the only thing it might vary a little bit might be on the basis of hours of operation, because that has been calculated on the basis of 16-hour days.
Thanks, Catherine. Okay, now they're coming in a flurry. People have found the chat. So clinics operating a GPRC able to apply? Yes, no restrictions on that. Would Medicare fees be chargeable to Medicare patients?
I'm not, they should be bulk billed. You know, the intent is no out of pockets. And even patients who are not Medicare eligible are expected to be cared for through this model, again, at no out of pockets. Is that the question that was being asked? Medicare fees, I'm assuming, is MBS billing?
I'm happy to take that, Catherine. So yes, if the client that presents has a Medicare card, you can bulk bill Medicare, and those arrangements have been cleared. If the person that presents doesn't have a Medicare card, you will see them as well, and that is what's covered off in your weekly fee, or your monthly fee, sorry, not weekly, but monthly fee. However, but there will be no private billing at all. So it's either bulk billing or paid out of your the PPCC funding.
So there's a question around any assistance or priority with recruiting doctors due to restrictions. So that is one that we did prepare an answer for today, that we actually might circulate an answer to that query as part of the feedback, as part of the questions, to make sure that I get that answer 100% correct. Imaging services are mandatory on site. Catherine, I think from your slide, ideally,
Ideally, but we do accept that they may not be on site, but they need to be not too far away and accessible in those after hour periods. And there needs to be a sort of formal arrangement to make sure that, you know, that service is responsive, I guess, to what might be a need for a quick turnaround.
The question around destination and how within that sort of 6 kilometre radius, we will take that one on notice and get back to you on that.
And the next one we'll take on notice, Bianca. So the overseas students, we will reply to that on notice.
Thank you. Sorry, I didn't get as far as that one.
That's okay.
And similar to, there's another question that might have just been sent directly to me. If sites are a distance from any EDs, will they be considered? I think so there's specific EDs that have been chosen to be part of this, so they would need to be within the localities of those specified EDs, if that's answering that question.
There is a slight variation on that with 2 satellite locations that have been identified, and that's mainly to sort of look at that sort of growth catchment for a health service, and where there are a lot of residents from those postcodes actually attending the ED that we're trying to alleviate the pressure on. And I guess over time we would hope that people won't bother going into the ED, they'll actually go to the local service.
And I suppose in those cases, then there's a locality-based sort of criteria for that, to capture those. And there is just a question which might relate to all of the online applications, whether there's the opportunity to access the questions in your online systems, Marita, that you're talking about as a printable or downloadable version to use to prepare for the responses. But that's something that we might need to check with each different PHN. Another question that we just might take on notice is around the increase in presentation and needing to see, allow GPs to see beyond 60 patients a day, and potentially concern with MBS. So we will take that one on notice as well. And how is it intended that the data will be captured and separated from the clinics? Oh, Marita, you go.
So we have, just to high level response, we have worked already with the GP respiratory clinics as to how we collect the data from that activity as opposed to their day-to-day GP clinic. And we would be utilising similar strategies. We'll be working with each successful site to actually get that set up. So there will be processes within things like Polar or PenCat that actually allow us to do that.
Thanks, Marita. Jane, it looks like you've got your hand up. I'm going to see if it works if I ask you to unmute. I could be. Jane, is that letting you unmute? No, I'm so sorry, Jane. I don't seem to be able to unmute you, which is annoying. If you could put your question in the chat. So we answered the can a site with a GPRC be considered for the PPCC earlier, which is there is no restrictions. In terms of the MBS, the phone consultations, will the 2030 rule apply? There's been some conversations that we're having, have been having through the GPRC work, so we'll respond to that as well. Sorry you're having troubles with your phone, Jane. Regarding the staffing, yes, that was alluded to in Catherine's presentation around the staffing requirements of Dr. GP and admin.
And we'll respond to that in general for everybody.
Yeah. And similarly, the question just around the, we'll respond to the questions around data, as Marita said, which would link in with the clinical software question as well. Excellent, Jane. I'm not sure if you've been able to type. It might be a bit tricky if you're on the phone. So please feel free, and this is to anyone as well, to put other questions directly to your PHN if there's other questions that you have after this. But is there anything else? Just as we seem to have slowed in the chat, but we'll certainly take a copy of the chat, and as I said, work on responses to those for you.
I suppose, Bianca, just to say, please don't hesitate to send your questions in. We want people to have the best information possible to make their choices, whether they apply for this or not, on how they present that. Each of your sites, you may be asked to redirect your question, but they'll give you the redirection. So go to your own or the local PHN that is supporting the ED that you wish to apply for, and make sure you get those questions in there, because it's really important.
Yeah, agree, Marita. So if there is no other questions, just to reiterate that thank you so much for joining us and showing interest in this initiative. We think it's really exciting. And as Marita said, all PHNs are really happy to take the questions, and it's great to see so much interest in this. There is just a note that some of the applications do have the word limit in there. So again, just with what Marita was saying, have enough time to make sure that you're not going over that word limit that might impact on you being able to submit through those electronic systems. There's a question around how much is the monthly payment, which we did mention earlier, and is in the EOI documents of 180,000 a month. Now I'm just saying that, I'm just second guessing myself.
No, you're doing fine, Bianca.
Excellent, great. I just didn't want to say that the wrong thing. And there's another question in the chat that we'll get back to. With the expansion of doctor and nurse numbers, what timing is being sourced on the expansion?
We'll get back to them on that.
Great. Sandra, that will be a question that we respond to. We'll take that one on notice about the 80-20. Great. Well, thank you so much for joining us. Thank you to Catherine for providing the Department of Health overview, and for Marita for helping with the questions. And thank you for all of you for coming along. Hopefully that was useful. As we said, we'll circulate those questions, and we'll also have this recording and the presentation available as well. So thank you very much for giving up your time.
Thank you, everyone.
Thanks, everybody. Bye.
Thanks.